So this is a very important aspect, I think, because to make a long story short, over the years, we've learned a lot on the genetic landscape of ALL in children and in adults. And what is important is, as we often say to our students and postdocs and fellows, is that a better understanding of the biology of diseases often translate in better prognostic stratifications and management and outcome. And certainly ALL is an example of this. And so in my talk, I will cover what we know now on the molecular classification of B lineage ALL and also T-ALL. And to say it up front, I think for the B lineage, certainly this has translated into very different forms of treatment, while in TLL we have less options so far. But this will translate one day, and the more we know the genetic landscape and more opportunities we have. So in ALL, I will touch some examples, and I will certainly touch upon the Philadelphia positive ALL for, I would say, 2 or 3 good reasons. One is that it was and has been for a long time the worst subgroup of ALL in terms of prognosis, where the only option in the past was an allogeneic transplant when doable. And the other point is that in the adults, this is by far the most frequent genetic abnormality. And third point is that over the years, new drugs have been made available, and particularly tyrosine kinase inhibitors. So we're talking about targeted treatment for this subgroup of genetically identified cases. So this means that it is absolutely mandatory that we define if a given patient has the BCR-ABL at diagnosis. This in all ages. And I would like to add, even in the elderly and very elderly, because now with the availability of TKIs to treat patients, we can treat a 70-year-old, an 80-year-old, and 90-year-old patient, even with a hope of putting this patient to remission. Now, in the old days, this would have been not only unthinkable, but in fact, most elderly patients in the old days simply got palliative treatment. So the genetic landscape has to be identified. This is one of the practical application, I think, that is a must today. We have to identify the Philadelphia positive. And I will also show some data that how this is related to a much better prognosis for the patient. And then I'll touch upon other subgroups. One is a Philadelphia-like ALL, which is another genetic subgroup that is important because it still has an unfavorable prognosis. And now we have ways of identifying early these cases, and this will translate very soon into more targeted treatment. And I'll give the audience data on this. How this has impacted in clinical trials. I will mention a little bit also on other genetic abnormalities, for instance, the ZNF384 subgroup and the prognostic implication of this. I think I will also cover, although it's not specifically the topic, but I'll cover MRD because MRD monitoring is a key factor in ALL and should be done in all patients. And this is often based on the genetic profile of given patients. So that is why it's so important that diagnosis we extensively profile them, because many of these cases can be monitored with a specific genetic abnormality. Philadelphia is one, but it's not the only one. So I think these are the points. And at the end, I will also add how we are becoming more refined in the genetic monitoring of these markers in the MRD monitoring, which is slowly, let's say we're improving, because so far it's done by quantitative PCR for genetic lesion or for the immunoglobulin and T-cell receptor genes, but we can work on that, and there are data already published and some submitted indicating that, for instance, by using digital droplet PCR, you can refine the monitoring of minimal disease by quantitative PCR. So although this is not in the guidelines yet, it's not standard, it probably will in the future. And I will finish in this talk, and I'll expand even more in the other one, underlining that all this can be done if you have a network of laboratories. It has to be a very close and integrated work between the clinic and the laboratory, and the laboratory with an S at the end, laboratories. And this is obviously not widely available. So this is one of the key points. I expect the audience being from many parts of the world, and unfortunately realities are very different. We in Italy and in many countries in Europe, we have multi-center study groups, and very often, and this is the case for ALL, the biology is tested centrally. So we have central laboratories utilizing standard technologies. And since the management of ALL is always more personalized, this is a key factor to try to offer always better treatment options. And to conclude, I think it's important to underline how prognosis change. I mean, we know in children now in the lucky countries, the long-term survivors are in the range of over 80%, approaching 90%, in fact. In other ALL, it's less good, but we are in TALL, we are long-term survivors about 60-65%, and the B-lineage ALL is about 50 to 60%, including even the Philadelphia. So it's not perfect yet by any means, but it's certainly consistently increasing, and this is largely through the genetic understanding of the biology of the disease.